I'll survive. Good morning, good afternoon, good evening, depending on where you are in the world. Welcome to one of our many webinars, and this time, now and tomorrow. Again, my name is Kilian Songwe. I am the president at the Global Healthcare Public Foundation. A Global Healthcare Public Foundation has been around for the last 18 years, doing a lot of work in standards and supporting organizations to develop a strong management systems for their different enterprises. So today, to be able to talk about healthcare now and tomorrow, we're just looking at what is actually going to happen. The entire healthcare is going to go digital in the next few hours, if I may say that. And the reason why I think it's going to go digital in the next few hours is there's already a study that has been done, which I'm going to talk about when I go into the presentation. But as of today, there is already a number of people who want to access healthcare remotely. But coming with COVID-19, what we're going to have is we're going to have more people who are going to try to access healthcare remotely. So just to be able to get into healthcare now and tomorrow, there could be no better place to start from, but to look at the World Health Statistics SDGs from 2019 and to compare it against what the UNECA in their 2019 report, Healthcare and Economic Growth in Africa, actually reported. So actually I used these two bases, the SDG report from 2019 and the UNECA report on healthcare and economic growth in Africa to be able to look at where we are going to post-COVID. So the Sustainable Development Goals, and the one for healthcare is Sustainable Development Goal number 3. And just looking at Sustainable Development Goal number 3, the goals in total that have been looked at, and predominantly the interest of the SDGs has been to reduce poverty, hunger, disease, and want. And SDG 3, global health and well-being, is the basis for where I want to speak from today. So just to be able to look at what is going on, I want to look at the 17 different subtopics that are under the global health and well-being under SDG 3. And I want to look at them from a pictorial point of view. There is maternal mortality, newborn and child mortality, a big issue across the world today, communicable diseases, and that's growing. Then non-communicable diseases and mental health, substance abuse, and then of course, road traffic injuries. This is just going completely out of hand. But then as we look at what is going on here, what we have is by 2030, reduce global maternal mortality ratios to less than 70 per 100,000 births. That is still a really huge number to be looking at. And for SDG 3.6, by 2020 to have half the number of global deaths and injuries from road traffic accidents. And that still continues to be a big problem. So looking at going further, 3.7, we have sexual and reproductive health, still a really big area. And we're going to look at some of these in some more detail. Universal health coverage. Universal health coverage is beginning to become one of the big things that all the nations are trying to get as they pool all the different resources and ensure that universal health coverage goes across multiple sectors. Mortality from environmental pollution. You know, it's very interesting to think about what happened during the period of the lockdown across the world. There was a climate study that was done that showed tremendous progress in climate change. And in just 3 months, there were no planes, there were no cars, and the whole world literally came to a lockdown. And what a phenomenal good it did to the environmental pollution. Then, of course, there is tobacco control. That still continues to be a big thing. We went from regular tobacco to electronic tobacco, and now we found out that electronic tobacco is most probably more harmful than the regular tobacco, and so that is also going out of business. Then development assistance and vaccine coverage. There could be nothing more important than vaccine coverage today, as we in a mad rush to be able to get a vaccine for COVID. There is a number of studies going on today to be able to get a vaccine for COVID all across the globe. And that's a very big thing for strategic development goal number 3. And then, of course, the health workforce. We've never ever known how important the health workforce is until COVID-19 hit. And then we could see the nurses, we could see the doctors, we could see all kinds of healthcare officers to support the general population. But again, this is a population that needs to be taken very good care of. Then national and global health risk. Yes, of course, that's where we are today. And then mobilization of resources. Mobilization of resources. Mobilization of resources is actually a really big thing today. And one of the big things that has happened with mobilization of resources is we've actually seen that there is a need for us to start moving from the global industries to more local industries. So when you think about the supply chain with COVID and testing across the continent, across the globe, one of the big things that we found was mobilization of resources. We couldn't get test kits to places that really needed it and needed it soon enough. So we need to actually start considering the whole global industrialization to more local industrialization. And then, of course, there is child malnutrition, another really big concern. Drinking water, we're going to see the problems around drinking water and potable water. We would come to learn that potable water is very, very important if we're going to continue to talk about hand washing and reduce the spread of COVID. Sanitization and hygiene. This is something that continues to remain. Many societies, in many cities, many countries, the issue of sanitization and hygiene is still very big. Clean household energy. The number of deaths is so countless from the number of people who die because of clean household energy, from using coal, using paper, using plastic bags to be able to make fire, and all in the name of trying to have a good meal. And then there are clean cities. Clean cities. Every country in the world we want to make a clean city out of. And so this is just a really nice picture of a clean city and the hope that we have as we move into 2030. Then natural disasters, that's still a very big concern. Violence. In the last 3 months of the COVID, starting March, from March through June, there has been such a tremendous report of domestic violence, and that is a huge indicator when you look at the SDG 3 on health. Then, of course, statistical capacity building. That's also a really important place to be, because without data and more data, we're not going to be able to support the healthcare systems to the best way possible. So going forward, now that we've looked at the 17 areas under the SDG 3, this is an interesting slide, because this slide looks at the global health expectancy and the healthy life expectancy between 2000 and 2016. When you look at the slide here, it talks on the slide on your left, actually, you're looking at males versus females. And we're looking at years lost to healthy life expectancy. When you look at the males, they start off from just about below 60, that would be somewhere around 56 years old. And then they go up to just a little 61 years. And in the same period, when you look at the healthy life expectancy for males and you compare it to those of females, this is at birth, you instantly see that the healthy life expectancy of females, when you move from 2000 to 2016, is certainly much better. Actually, it's almost 4.4% better than it is for men. Now you jump from at birth and then you go to age 60. Again, you're looking at healthy life expectancy at age 60 once the males and the females get to 60. Again, what you see here is in terms of additional healthy life expectancy, you see again that the females have well over a good 15 years better health life expectancy than men, which is very interesting to note. So now, one of the big things that has been looked at is the cause of death that contributes to the difference between the healthy life expectancy for male versus female. And when you look at this graph, I'm sorry, you have to twist your head over to be able to see it. But when you look at the 13 indices that actually contribute to the loss of life for male over female, and from all the way from ischemic heart diseases down to kidney diseases, you have violence, liver cancer, breast cancer. Well, that's going to be more for the females. So those 13 indices actually contribute death over female death. Life expectancy and the healthy life expectancy by sex, this is done by WHO and the World Bank in terms of income indices. This was done in 2016. It's very interesting to look at this when you look at life expectancy at birth. This is a really important comparison because it's life expectancy at birth and then it's life expectancy when you live to 60 years of age. So just to concentrate on Africa for now, what you see when you look at the African region is life expectancy at birth is 61.2 years. And when you look at the healthy life expectancy, it suddenly drops by almost another 9 years. There's a huge drop there. Then once these people are able to live up to the age of 60, and then you look at the life expectancy at 60 for Africa is another 16 years, regular life expectancy. When you include the healthy life expectancy, then it actually drops by another 4.4%. So literally what you're seeing here is that on average, the healthy life expectancy of an African male or female is relatively short compared to their lifetime on Earth. So if you look at whether it's 53 years at birth, or it's another 12 years reduced, compared to if you picked any of the other countries, if you picked Europe, for example, it would be 77 years at birth, and 22 years at the age of 60 and above. And then you look at the life expectancy for Europe under the Haley, it's 17 years. That's a good 5 years on average above the life expectancy or the Haley for Africa. But now when you take the life expectancies and the Haleys and you put them against the World Bank income group, it's also an interesting figure to look at. You look at the low income countries, which is where predominantly most of Africa is, and a little of Latin America, the new breakaway republics of Asia, you would see the life expectancy at birth is 62.7. You compare that to Africa, 61.2, basically 1.5 years difference. Then once they are able to make it up to the age of 70, low-income countries 17.1 versus Africa 16.6. But now look at the Haley life expectancy after, the healthy life expectancy at 60. So for low-income countries, you're 12.9. For Africa, you're 12.5. So when you look at that particular index, and you think that the other low-income countries is most probably Latin America, the new breakaway republics of Asia, you actually see truthfully that Africa actually contributes a huge number to the shortage or the disadvantage Haley for the most of the people that are living globally. So maternal mortality ratios is another really big thing. In 2020, this should not be a place where we are, but maternal mortality deaths per 100,000 births. Again, if you look at the African continent, you would notice that for the most part of the continent, maternal mortality ratio, the MMR for Africa, is between 500 to greater than 1,000 live births. That's in 2020, that's completely unacceptable. But again, these are areas in which the different governments need to increase their contributions to the Ministry of Health, to their various ministries of health, so that things like the MMR ratios, the maternal mortality ratio, can truly be brought down. It's still very, very high for Africa. And again, this is a graph that was done. This graph was done in 2015. So this is 5 years ago. And 5 years ago, it hasn't moved tremendously big. In the last 5 years, it has changed by just about 4.4 percentage points. Then if we move on, now what do we have here? We have births attended by skilled health personnel. Yes, there has been an increase in births attended by health personnel when you look at the period between 2000 and 2005, 62% increase. And 81% from 2013 to 2018. That's just 2 years back. And you look at the percentage for the continent of Africa, that's barely just over 50% of an increase of birth attended by skilled healthcare workers. Now you take that and you look at the global maternal mortality rate, which has fallen, by the way. Global maternal mortality rates have fallen by 37% between 2000 and 2018. However, in 2015, we still had 303,000 deaths recorded. And on the Africans, for every 185 children born. On the African continent, one woman dies for every 185 children born. So that's still high. So one of the interesting points to note here is, while the MMR fell, and while the African continent has actually done better, what has actually happened is the childbirth has actually only reduced by 2 percentage points. So you have a lot of the mothers have moved from having 9 children down to 6 children. So that percentage point has moved very slightly. Total fertility rates have still remained very high. And so in spite of the decrease in the MMR rate, we still have high rates for Africa because the fertility rate has not actually met with the global rates. So let's look at some other reasons for death. Probability of dying from cancer, diabetes, chronic respiratory disease between the ages of 30 and 70 years, or a chronic vascular disease. When you look at Africa again, it's interesting that what you see here is the females have actually done much better than males. The ratio is slightly similar, but when we talk about non-communicable disease deaths, declined by 19% for both sexes between 2000 and 2016. The decline has been slightly higher for women than it has been for men. And again, you go back to the 13 indices that I showed you earlier on for the reasons for which we've got more male deaths for females. But also, you've also got a much better healthy life expectancy for females when they live longer. Now let's look at this from an economic point of view, because somebody has to pay for healthcare, somebody has to pay for the treatment, somebody has to pay for a healthy life. And one of the things that we note as we look at this is, while the population growth in Africa is actually going to double by 2050, if you think about where we are now in 2020, we're just a little over 1.1 billion people. And then we're looking at by 2050, that is going to be another 2.5 billion people. So that we're going to have a huge increase in the population. And the youth between 15 to 24 is also going to increase, just like 0 to 14, which means we're going to be left with a working population with an average age of somewhere between 44 to 45 years of age. That would be the big working age as we go into that group. So what you have down here in my second slide here is you look at what is happening between 1980 and 2015, the child ratio, 0 to 14 children, 45%. Then you go from 2015 to 2050, that ratio is 41%, which means there's just been a very slight shift. And then you look at the next group there, which is the age of 15 to to 24, that's 19%, pretty much about the same when you look at the next projection. And then up, that's where we begin to see a shrinking in the population. But then, as I said earlier on, that only typifies when you look at both groups and you look at the next working age of the population, you're going to be looking at a working age of 44% of the age group would be just above 45 years of age, as opposed to between 1980 and 1915, where the age group between 25 and 45. So Africa's biggest challenge as we go forward, what is Africa's biggest challenge when it comes to our healthcare and our economy? The big thing that we have to look at here is the demographic change. As we've just looked at, there is longer life expectancy. Life expectancy has moved from 48 and 50 back from the HIV days to now to 60s and 61 years of age. But also we've also added to that the healthy life expectancy days, which is another 12 years on average for Africa. Then we have urban growth. Urban growth, there's just nothing we're going to do about this. People are going to continue living the different slums, and they're going to keep on coming into the big cities. But also the big cities, where the people are living from and coming to the big cities, are also beginning to become cities themselves. So urban growth, fertility rate, which has not dropped that much, global rates, means that we're going to continue to have a high urban population. Then there is epidemiological changes. Non-communicable diseases continues to be the big thing on the African continent. And then qualified health workers, it's a really big challenge. As we prepare to get into the COVID era in early March, there was a quick study that was done by the McKinsey and Company group that showed very clearly that on the African continent, we had less than 25,000 ventilators for a billion plus people. That's a serious shortage. That's a big challenge. And even after preparing and beginning to come and go internal, where we're having a lot of the governments begin to change factories to be able to produce, whether they're producing ventilators, they're producing intensive care unit beds, and we're getting more people to do this. We still have a shortage of qualified healthcare workers, and that's a very important challenge for Africa. Then limited availability of quality medicines. We need to continue to work on this. We need to make sure that we get more research on the continent. We need to make sure that we build our pharmaceuticals. And again, this is a very clear challenge that we saw with COVID-19, because one of the big things was the supply chain. While Europe and the Americas were stacking up for the next surge, what that meant to the African continents and to the less resource poor countries was they were not able to get the same resources that they needed just for a first round of testing. Whereas Europe and the Americas were going into a second round and preparing for an even bigger round of testing. So we need to be able to make sure that we can get this quality medicines. We need to strengthen our research laboratories, and we need to be able to increase the government share to this area. But also something I am going to speak to in a few seconds is to increase the private-public partnership. I think private-public partnership is going to be a very big addition, and we're going to see what that does as we go down. So then, of course, there is the distribution of age-specific disease burdens in Africa. When you look at 0 to 14, and you look at communicable diseases in Africa, when you compare that to the rest of the world, is still very high. When you compare that to the dailies, we're looking at 567, and then you go up to non-communicable diseases, it's only 99. And then injuries, and for the most part, these injuries are mostly motor vehicle injuries. Then when you move to the next age bracket, which is the 15 to 24, what you see is while there is a shrinking, that shrinking actually does not put Africa in a much better position. It only means that what has happened now is our communicable disease is strong, but our non-communicable diseases also increased. Injuries fairly the same. And we go into the age bracket of 25 to 64. The rest of the world is literally coming down on communicable diseases. We're still on the African continent, you're still at 201 to the dailies per 100,000 population, per 1,000 population. But then there is a new surge, which is the non-communicable diseases. That has also begun to grow. And then when you look at the ages 65 and above, which actually takes you back to the correlation on the HALEs. When you look back at the HALEs and you look at the actual healthy life expectancies at 60 and above, there is a huge drop. But then when you look at that huge drop and then you come back to this, what you actually see is that non-communicable diseases suddenly has increased for that particular group, 65 plus. While when you look at the rest of the world, there is a reasonable shrink there. So this is what we really need to pay attention to. You look at two very critical age groups. There is 0 to 14, and then there is 60, 65 and above. So what we have on the African continent is a very interesting scenario where we have from 0 to 14, communicable disease burden, which is very, very high amongst young people. So we have a mortality rate there, which is directly associated to communicable diseases. Then you move on, and then once people are at 60, 65, then we have a completely different issue happening here. We have the non-communicable diseases that suddenly builds up. So we're looking at a huge opportunity for Africa going forward. This is a huge opportunity for our pharmaceuticals. This is a huge opportunity for the business. When I talk about the triple P, the public-private partnerships, there is a huge opportunity here when you look at the two different segments, 0 to 4 years of age and 60, 65 years of age. And then when you put in the healthy life expectancy into this mix, it suddenly means that if we can do something to be able to extend this life, then we have a much better health life expectancy and a much more useful life expectancy as we go forward. Then we look at the current share of health expenditure in Africa. This is, when you look at health, when we look at the health expenditure in Africa, what you see between the low income countries and the low middle income countries and the upper middle countries, as you see a reasonable shift in where the expenditure is happening. But it's also interesting to note that even for the upper middle income countries, the actual expenditure of out-of-pocket to healthcare is actually small. So you have two things that are happening there. Out-of-pocket for healthcare is small on the high upper middle income countries. And then you have government contribution to healthcare is also small. What that means directly when you look at out-of-pocket expenditure is you have the less fortunate, if I may use the word, of people who do not have enough income. They actually bear the burden, and as a result, they end up they seek healthcare at a much advanced stage of sickness. So you look generally, if you look at the upper middle income, you have 58.4% of that population that would actually spend money out of pocket or government expenditure versus the out of pocket, which is just at 25%. And then you come down to the low income countries, you also see there that the government contribution and the out of pocket contribution is relatively small. And what does that leave you with? It leaves you with external health expenditures. And that external health expenditures is actually borne by the less privileged or the people who really cannot afford that. So that is something that, again, as we talk about going forward, these are areas that both the private sector and government need to be able to come in if we're going to talk about universal healthcare. Yeah, this just shows you where the line is and how the countries, the different countries fall on the, and how the different countries actually fall. So if you look at the dotted line going through, and then you have Egypt, you have Nigeria, you have on the lower side of the curve, and then on the upper side of the curve, you have Tunisia, you have Botswana, you have Cape Verde. And this is actually an actual representation of the domestic general government expenditure to healthcare. And we're looking at this is actually the relationship when we bring in the triple Ps. So talking about public-private collaborations in healthcare delivery, there are many, and I actually just chose a few to look at here. There could be a number of them that we could actually have a discussion about. But just to look at contracting in and out, governments contract with private providers to deliver health services. This is beginning to happen. There is, you could see this in Senegal and South Africa. That's where you see a lot of this. licensing and accreditation, as we try to improve the quality of healthcare, is beginning to become a really important place. So the number of accrediting body and licensing bodies on the continent are beginning to grow. So governments extend licensing and accreditation systems to include provisions for private sector providers. This basically strengthens the quality of the private health services. Governments can monitor the care that private providers can offer. And there's a good test of this in South Africa, again, Tanzania and Zambia. Then there is also the issue of regulation. By updating and harmonizing laws, policies, regulations, and procedures, government authorizes private provisions of service and products. And this is really important because what that does is then the manpower in government, which is relatively thin, can actually go into the private sector to be able to support us. And then public-private partnerships. Still, you look at what is going on here in the case of Egypt, Ghana, Lesotho, Nigeria. Basically, what you have here is the private providers and business and government coming together with the international partners and actually trying to solve basic problems that are going on. And then there is training and continuous education for private providers. That is still another important area. But all of these areas just shows us the relationship between the public-private partnerships, government, as what they could do if they're coming. However, I must say that of over 178 different PPPs that actually exist on the African continent, 50% of them are actually being implemented in only 10 countries on the continent, 54 countries. Only 10 countries are actually implementing 50% of the people of the triple P, which means there is still a lot of room for growth. There is a lot of room to study what is happening. And then there is a lot of room for us to be able to build universal health coverage. This is a look at the distribution of the PPP cases by the sub-region in Africa. And as I said, there are 178 cases. When you look at what is going on here, East Africa happens to be well ahead with 32%. Eastern Africa, yeah, that's Kenya, 9%, Tanzania, Uganda, and Ethiopia. They're doing a great job here with the triple P. And then the very next one to them would be 31% in the West African zone, Nigeria, Ghana, but also these are very big economies, Nigeria, Ghana, and Senegal. And then the next one would be 22% would be Southern Africa, which is South Africa itself and Mozambique, and then the Central Africa, which would be Cameroon at 6%. But again, basically what this shows you is the room for growth. And when you look at 178 cases of a triple P on 54 countries and the ratio of the division, it means that there is a lot of room for growth to be able to happen here. And there is tremendous support that can go to helping and supporting the different African countries to strengthen the healthcare going forward. And I think one of the big things we see in this is as we go into the post-COVID era, this is a tremendous opportunity for both pharmaceuticals, for government and the private sector to begin to look at how collectively they could all come together to be able to strengthen healthcare going forward. I just mentioned, I just showed this very quickly, multi-area engagements and the triple Ps. This is a slide that just tells us who is involved in medicine and other medical devices, human resource, and this list, I don't have everybody here, but this just gives us a sense of what is going on with the triple P and where they are and what they're doing, for example. And this is out of the McKinsey. This going forward. In 2019, the use of telehealth was reported at 11%. Yet there is a projection that as we move forward in 2020 and going on, there is 76% new interest in telehealth. And this is because of COVID. So again, as I said earlier on, the area of data, the area of innovation, the area of telehealth is going to be a big gain. It's going to be a big boost. And that again poses a great opportunity for the African continent going forward. Health vulnerabilities. This is a very important thing. When you look at the African continent and you look at health vulnerabilities, you have chronic kidney diseases and its prevalence in Africa is getting higher when you compare that to cardiovascular diseases and its prevalences across the world. But again, what is important to note is when you think about the previous slide, is that when you go into the age bracket of 60 and 65, then all of a sudden you have that tremendous jump into the non-communicable diseases. So going forward, virtual health applications that we need to look at, because this is where the world is going to, and this is where everything is going to happen. So you have telehealth. There are three phases of telehealth. It could be synchronous or asynchronous. Basically, people are going to be home and they're going to try to access healthcare virtually, or they're going to have to do things like their x-rays. There is the digital therapies, replacement therapies, evidence-based therapeutic interventions, or treatment options. Treatment options is actually the really interesting one. Now we have people who are using bracelets to be able to report what their adherence is to their treatments directly to their doctors. And then there is care navigation. So we have three big areas in telemedicine that is going to happen as we go forward in the post-COVID era. There is telehealth, digital therapies, and then there is care navigation, patient self-directed care, and e-triage. Basically, you go on your phone, you talk with your doctor, and then there is a couple of things that can be eliminated before you get into hospital. So vulnerability to the virus spread. I said earlier on when we were looking at the SDG 3, we're talking about water. African access to household hand washing facilities is low, very low. When you look at this in terms of percentage, only 34% have basic water and soap. And then you have another 30% limited without water or soap. And then when you go up to facilities where there are no facilities, that's a good 36% of the continent does not have access to water and soap. And this is supposed to be a major preventive need as we talk about curbing the spread of the virus. And then you look at this other slide to the right, 1.8 average hospital beds ready, capacity of hospital beds. Again, that's a really small number when you look at the continent and its overall. So as we go forward and we think about the spread of the virus, and I'm not only talking about COVID, it could be any other virus, it could be another epidemic, it could be another pandemic that could hit the continent, and something problem for 36% of the continent has access to potable water that can actually help them if you talk about washing hands and being able to stay. On average, Africa has an average of 1 bed per 1,000 people compared to 5.8, 5.9 in Paris. That's a huge difference, tremendous. So again, I opted to use two very simple bases to be able to make this, have this webinar. When you look at the SDGs and then you look at the UNECA report for both the same years, they're both 2019, and you look at where we were before, where we are now, and the opportunities that lie ahead of us. I think Africa continues to be the greatest opportunity for business, the greatest place to be able to promote healthcare, the greatest place to increase the life expectancy, the greatest place to increase healthy life expectancy as well. And to be able to make sure that our communicable diseases in the 0 to 14 becomes better, but then the life expectancies and the non-communicable diseases in the plus 60 and above also becomes better. I never like to end this without telling you about some of the things we're doing, and also to be able to tell you to stay safe, get your temperatures, and if you're part of the 34% of the African continent that has access to water, wash your hands, use soap, sanitize if you cannot have that, please wear a mask, and none of this, and I repeat, none of this is going to absorb you of social distancing. We need to continue to maintain our social distancing, wash our hands, wear our mask, and then we can be able to curb the virus. I want to acknowledge the World Health Organization for their report, the 2019 SDG report, and the United Nations Economic Commission for Africa, and of course the McKinsey & Co. company. This is where the world is going to, and there we go. Thank you for joining us. If you do have any questions, comments, or suggestions at this time, please raise your hand, speak up, type in a question in the chat box, and I'll be very glad to try to answer. I know this is a lot to be able to absorb all at the same time, but if you do and you have a quick question for us, please do at this time so that we could try to answer. There's a hand up. Okay, let's give them permission to speak. Yes, Jacob, I guess you're the one. Are you going to say something now? Yes, Jacob, we're listening to you. I think you have to unmute yourself. If you're speaking, you have to unmute yourself.
Unmute.
Wonderful, wonderful.
Yes. I think you're picking me now.
Yes, I can hear you loud and clear. Thank you.
Okay, thanks for the presentation. I've appreciated so much the statistics, and especially on the way forward of the telemedics. My question is, yes? Hello? Oh, I think I'm just off now. That's happened to my work.
Yes, Jacob, what's the question? I'm sorry, we lost Jacob there. If you don't mind, Jacob, if you can still hear me, if you would type in your question in the chat box, I'll be very glad to answer. Anybody else who is listening and has a quick question or comment, share some ideas about where we are. That would be most appreciated. Okay. Are there any actions to address mental health needs associated with the pandemic? Yes, there is. As there will be enormous long-term consequences to families, yes, I agree. Preliminary studies have identified high levels of COVID-19 expectations among healthcare workers. It feels as if to say the focus is overwhelmingly on secondary care. How do we ensure that primary care services are better supported and recognized? MOH delayed the inconsistent pandemic response with fragmented, splitted responsibilities among multiple adversaries. The contrast with more decisive and effective responses. Well, I just tell you on the first one, mental health is still a really, really important thing. Mental health is being looked at. It is one of the things that the SDGs, SDG 3 is looking at when we talk about good health and well-being. In terms of preliminary studies, high levels of COVID exposure. COVID exposure, if you look at the continent of Africa and you look at the number of healthcare workers that have actually been infected, it is actually tremendously low compared to our European counterparts or the counterparts in the Americas. So it is still being properly controlled here. So there is a very good control in terms of healthcare workers and the PPEs that they have gotten. Yes, I recognize the fact that PPEs are still short. There's still a huge shortage, and that's again what I was talking about in the supply chain. The supply chain needs to be developed. We need to stop relying on global industrialization, and we need to go a little inward and see if we can start producing some of those things on the African continent and in the different sub-regions, whether it's the East African region, the West African region, or the Southern region, or any of the regions. Overwhelmingly on secondary care, I think I wouldn't say I think that's the case. Absolutely, I think the focus has been on the general healthcare of all healthcare workers from all angles. There is great support to all healthcare workers. Just a few days ago, the United Nations Secretary General's Guterres was actually speaking to healthcare workers, and he was extending his deep appreciation to all levels of healthcare workers, whether they were administrators or they were cleaners. So I must say that from where I stand and from what I see, I think there's been tremendous support to Ministry of Health and inconsistent pandemic response. I don't know which Ministry of Health is being referred to here. But I must say that as I look at the different ministries of health, I must tell you that each government had to respond differently to the pandemic, whether the decision on how they were going to lock down, how stringent it was going to be, how they were going to open up, and how they were going to start up. Each government has had to respond differently. Again, we have to look at what are the sizes of these countries. We need to also look at the economies of these countries and the different responses that the different countries have actually brought. So each government has had to respond differently. And in one of my webinars a couple of weeks ago, I showed you the response from Nigeria all the way to Lesotho. Lesotho had a phenomenal lockdown. But just a few weeks ago, Lesotho finally reported its first case, and I think there are now 3 cases. So there has been a different response from different governments and different ministries of health. But those responses has taken into consideration the different effects, both from an economic point of view and a public health point of view. So I'm a little hesitant to make judgment on any of these governments because, as I've said many times before, we are still studying COVID. We still need to have a long time with COVID to be able to appreciate its life cycle, be able to appreciate what we could have done better and what we can still do better. Okay. Well, I think we're nearing the end of our hour with you guys today. I thank you so much indeed for joining us for this webinar. It's always a pleasure to carry out these discussions, and it's always my pleasure to hear back. So if there's anything that you need for us to know, I'll be very glad to have the conversation with you for that. So you could reach us, drop us an email, give us a call at our Kololo office, drop by. Actually, we'd like to see you, so drop by. And we'll be glad to work with you, whether it's on management systems for your organizations or your business, or it's having a conversation on what is going on in the world today and our healthcare industry. Till we meet again next week, same time, same place. Thank you very much indeed for joining. Have a wonderful rest of the week.